Good morning, friends. In this series of Invasive Mechanical Ventilator, we are going to discuss part 8. In this module, we will discuss various alarm settings in ventilator, how to do monitoring of patient, and troubleshooting. So first we will discuss alarms. So alarms is most commonly ignored things we should not forget to set in a patient's because at times it may be life saving, especially in night. So in this Mackey ventilator, there's two buttons. One is alarm profile and another is this alarm picture. So once we press this alarm profile, so the screen will open like this. So in this, we have to set sound level from 0% to 100%. As we increase 0 to 100%, there will be increase in intensity of sound. So 100% sound level will make more noise. Then there are settings: pressure setting, mid ventilation, respiratory rate, and expiratory pressure. So pressure is peak pressure. We have to set upper limit because upper limit is most dangerous. Because once you cross upper limit, there will be chance of barotrauma. So we have to set upper limit. Then mid volume. This is mid ventilation. We have to set lower limit as well as upper limit. Respiratory rate, lower limit and upper limit. Lower limit is important because once patient is disconnected from ventilator, it will alarm ventilator. And expiratory pressure. This is like a PEEP. So we have to set minimum and maximum. So this is the settings we are supposed to do according to patient profile. If you are not comfortable to do setting of alarms, there is button of auto set. So once you press auto set button, it will set the alarm which is set by manufacturer. So once you press auto set, the upper limit of pressure will be set as 35, minute volume 5 to 14.5, respiratory rate 11 to 25, and end expiratory pressure 4 to 12. So this is inbuilt setting which is done by manufacturer, which come by auto set. So we take example. So we are taking example of respiratory rate. We have set upper limit as 20, means if patient respiratory rate goes beyond 20, there will be alarm by ventilator. So we have set 20. Now in this upper part, you can see there is respiratory rate of 19. So there is no problem. Once it will cross 20, in lower panel you can see 24. So it crossed 20, the alarm will get alert. You can see this is alarm, respiratory rate high. So we have to set alarm accordingly. Now coming to monitoring and troubleshooting. So first we have to see our goal to put a patient on ventilator. Obviously, in hypoxic patient or hypercapnic patient, we have to put ventilator. So oxygen goal is SpO2 is 88 to 95%. Same way, carbon dioxide, it should be 35 to 45. There should be no acidosis. So pH should be in normal range. And we have to give rest to patient's respiratory system. So patient should not have high work of breathing. So we have to reduce work of breathing of patient. And by the giving ventilation to patient, we have to take care of complications, especially barotrauma, ventilator associated pneumonia, and of course hypotension because of high PEEP. So what to monitor our patient? We have to monitor heart rate, we have to monitor oxygen saturation, respiratory rate, and patient's pattern of respiration. Once we are giving ventilation, we have to look if patient is struggling for breath or patient is in acidotic breathing or the patient is on gasping condition. We have to monitor blood pressure. We have to see carbon dioxide also by EtCO2 or by manual by ABG. We have to see about leaks. We will discuss in further slides. And we have to check our plateau pressure below 30. because above 30 it can create barotrauma. Now this is commonly asked question, which mode to be used. As I said earlier, you set setting in which you are uncomfortable. You can use pressure control, you can choose volume control. Both are equal, but there is certain little difference. Say for example, in ARDS. In ARDS, there is poor lung compliance. Once you set volume control, you have to push tidal volume, it will get increased pressure. So increased pressure will cause barotrauma. So to prevent barotrauma, we have to keep plateau pressure below 30. So in case of ARDS, pressure control is ventilator of choice because we are giving a limit pressure to prevent barotrauma. In patient of hypoventilation, where is ventilation is the problem, patient is not getting enough minute ventilation. In that patient, you have to keep tidal volume constant. We have to calculate how much ventilation patient required, how much mid ventilation. Accordingly, we have to set volume, we have to set respiratory rate. So where we can control tidal volume, volume control mode, because we have to set volume, tidal volume, and accordingly ventilator used to give pressure. So in case of hypoventilation, you can choose volume control. In case of ARDS, you can choose pressure control. So first, when you are getting patient, you have to choose control mode. You can choose volume control, you can choose pressure control, you can choose PRBC. And you have to choose tidal volume of 6 to 8 ml per kg of idle body weight, not actual body weight. It is idle body weight, which is calculated by using height. Respiratory rate, we have to choose 12 to 20. If patient is hypercapnic, you can choose lower respiratory rate like 12 or 14 or 15. If patient is ARDS or ILD where he needs more respiratory rate, you can choose 20 or 25, sometimes 30. But it should be less than patient's respiratory rate. If patient respiratory rate is 30, you have to choose below 30, 25 or 28. Then PEEP. So by default, we have to choose PEEP in all patients range from 4 to 6. You can increase PEEP accordingly if patient is in ARDS, or you can reduce PEEP if patient is having emphysema or anything. Then I ratio. We have to choose I ratio normal as 1:2. But in patients of obstructive airway disease, where we need wash out of CO2, in that patient, we have to prolong expiratory phase. So to increase expiratory phase, we have to decrease I ratio. So we have to decrease I ratio 1:2 to 1:2.5, like 1:3. So there is prolonged expiratory phase, and we know CO2 get washed out in expiratory phase. So obstructive airway disease like COPD, we have to decrease I ratio. But in those patients who needs more oxygen, like restrictive airway disease, ARDS, ILD, in that type of patient, we have to increase inspiratory phase because oxygenation occur in inspiratory phase. In that case, we have to increase I ratio. So 1:2 normal to 1:1, or in some cases like severe ARDS, we can reverse this ratio 1:2 to 2:1. This is called inverse ratio ventilation. This is seen in ARDS. Then we have to keep FiO2 100% initially, and we have to taper down accordingly with SpO2. And with this all setting, we have to keep plateau pressure below 30 because above 30 there is chance of barotrauma, pneumothorax, pneumomediastinum, surgical emphysema, lot of complications. After keeping patient on ventilator, you have to monitor by ABG and oxygen and by other parameters if there is low oxygen saturation. So now question is how to increase oxygen. So we can increase oxygen by increasing FiO2. If it is 50%, we can increase 80% up to 100%. If patient is having low PEEP, we can increase PEEP. So increasing PEEP can increase oxygen saturation. How? Because it prevents collapse of alveoli, as seen in ARDS, prevent collapse. Or it can open collapsed alveoli by keeping PEEP. Second thing, it increase FRC, functional residual capacity. FRC is the amount of gas which is there after normal expiration. So more FRC means there is more air, more oxygen for air for alveolar membrane oxygenation. So if increase FRC, they increase oxygenation. So to get more oxygen, we can increase P. Another thing is we can increase I ratio, means we have to increase inspiratory phase because oxygenation occur in inspiratory phase. So if there is problem of oxygenation, we can increase I ratio. And in spite of all this modality, if oxygen is still low, then when increase mid ventilation. By mid ventilation, by how? By increase tidal volume or respiratory rate. So this is the method to increase oxygen saturation. If patient is having hypercapnia or acidosis, and we know to relieve hypercapnia, we have to increase mid ventilation. Because by increasing mid ventilation, we can help patient to wash out their CO2 or reduce acidosis. So how to increase mid ventilation? Either we can increase respiratory rate or increase tidal volume. Then other method to wash out PCO2, we have to decrease I ratio. Means we have to increase expiratory phase because CO2 wash out in expiratory phase while oxygenation occur in inspiratory phase. So if you want to wash out CO2, you have to increase E phase. So we have to decrease I ratio. Normal is 1:2. We have to decrease like 1:2.5 or 1:3. So once you increase expiratory phase, you can reduce CO2 from alveoli. Then another is you can reduce FiO2 because in COPD or asthma, when there is hypoxic drive, if you are giving more oxygen, more oxygen, more oxygen, then the patient will retain carbon dioxide. So in patient of hypercapnia or acidosis, we have to reduce FiO2 also. So the acidosis management, if there is acidosis, we have to increase respiratory first rather than tidal volume. And we can increase up to 35. That is maximum respiratory rate we can increase. If pH is still acidotic or there is acidosis, then we have to increase tidal volume. But keep in mind, we have to keep plateau pressure less than 30 because after 30, there is chance of barotrauma. So increase tidal volume, but by the time you have to watch on P plateau pressure. If there is still acidosis, we have to increase expiratory time. So we have to decrease I ratio. So there is more expiratory time, more washout of CO2. So if there is still acidosis or raise CO2 in spite of doing all this thing, and we can allow hypercapnia, that is called permissive hypercapnia. It means we are allowing hypercapnia to occur because we want to keep our plateau pressure below 30. But there should be no contraindication for hypercapnia like raised ICT. If it is so, we have to give bicarbonate to increase pH. Otherwise, we can allow permissive hypercapnia. Another patient is having tachypnea or increase of work breathing. So we have to understand why there is increased work of breathing. So increased work of breathing could be due to hypoxia or hypercapnia or at last anxiety. because you are putting patient on ventilator, and ventilator is very uncomfortable for conscious patient. So if there is hypoxia, patient SRE muscle will come in action to increase his oxygen saturation. So you have to increase FiO2. If patient is hypercapnic, then you have to increase tidal volume or pressure support. And still patient is having more work of breathing, then we have to give sedation or paralytic agent like midazolam, fentanyl, vecronium, etc. So this is the method to reduce work of breathing. And this is the classical time pressure graph seen in volume control mode, volume control ventilation. And in volume control ventilation, we have to set tidal volume, and ventilator push tidal volume by giving pressure. So pressure will increase progressively up to peak pressure. So this is the maximum pressure. Maximum pressure means when there is airflow in the airway and alveoli, and the the pressure reach maximum, that is peak pressure. So peak pressure include plateau pressure plus airway resistance. When there is hold at the end inspiratory, there is no flow in airway, then this pressure is called plateau pressure. Plateau pressure means when there is no airflow in airway, the pressure exerted by alveoli is called P plateau. So P plateau pressure is alveolar pressure. Peak pressure is plateau pressure plus airway pressure. Then this is expiratory phase. So this is classical time pressure graph in volume control mode. So any patient in whom there is alarm of high peak pressure, so we have to rule out where is the problem. Whether, because we know the peak pressure contains two pressure, airway pressure plus plateau pressure. So this is plateau pressure and this is airway pressure. So we have to see which is culprit for increasing peak pressure. So what we have to see? We have to see this peak plateau pressure, and if there is increased distance of airway pressure, this distance more than 10 means there is problem in airway. So what could be the problem in airway? It may be small endotracheal tube, or there is obstruction by mucus plug or by anything, kinking, biting, or there is ventilator asynchrony. In that case also peak pressure will increase because of airway resistance. There is any blood clot or there is bronchospasm. So how to relieve bronchospasm? By nebulization. How to do, how to solve this problem, obstruction problem? By suctioning. So we have to address this problem by seeing this pressure time graph. If there is alarm of high peak pressure, but airway resistance is normal, there is high P plateau, means alveolar pressure is high. What could be the cause? Anything which affect at alveolar level, means ARDS, there is lower compliance. Pulmonary edema, there is lung collapse. Pneumothorax, effusion, air trapping, fibrosis, ILD, obesity, right main bronch intubation, and anything which causes abdominal problem like ascites, abdominal compartment syndrome. So these things compress alveoli and there is increased pressure at alveolar level. It will increase P plateau pressure. In this, airway pressure will be normal. So once there is alarm of peak pressure, we have to rule out where is the problem, airway problem or alveolar problem. So we have to treat accordingly. Then auto-PEEP. What is auto-PEEP? At the phase of end expiration, there is air retention in alveoli because of premature airway closure. So expiration is not getting complete. Before that, airway is getting collapsed. Seen in sleep apnea, COPD patient. So in every respiratory cycles, there will be retention of air at end expiratory. So you can see, so this limb is expiratory phase. So before reaching normal, it get close. So there is retention of air. So in every cycle there is retention. So retention, and in a minute of 1 or 2, there is much pressure generated in alveoli by auto-PEEP. So what will it do? It will cause hypotension because of increased auto-PEEP, and it could be barotrauma. So how to relieve? You keep patient away from ventilator for a short while by manual ventilation. So just disconnect and ventilate patient by embu bag or vein circuit. Then you can use external PEEP. So what is the difference between internal PEEP and external PEEP? Internal PEEP, retention of air in alveolar level, and external PEEP you are giving at airway, because you are giving ventilator circuit, no, so airway. So once you give pressure here in airway, the airway will not collapse in end expiratory phase. The airway is open, so the air which is there in alveoli will come out. So by keeping external PEEP, we can relieve auto PEEP also, but we should keep external PEEP lower than auto PEEP. If auto PEEP is 10, you have to keep external PEEP 8 or 7, always lower than internal PEEP. We have to decrease respiratory rate, because why auto PEEP is getting developed? Because patient is not having enough time for expiration. There is more respiratory rate, the shorter is the expiratory phase. So we have to reduce respiratory rate. Once respiratory rate is reduced, there is more time for inspiration and expiration. Decrease tidal volume and decrease inspiratory expiratory ratio, because we have to prolong expiratory phase. Because problem in expiratory phase, the patient who inhaled 500 ml of tidal volume is not able to expire. So we have to reduce tidal volume, or we have to prolong expiratory phase. That is a treatment for auto PEEP. Then what is leak? Leak is what you are giving and what is patient is getting out of from ventilator. So you are giving tidal volume of 400 and expiratory tidal volume is 98. So means there is leak. You are giving 400 but coming out as 98 ml only. So there is leak. The most common site for leak is inadequate cuff pressure. There is cuff in endotracheal tube. If there is leak, the air will leak out from side port. Another is circuit leak, and many times they leak from HME filter, and sometimes if patient is having intercostal tube drainage, that will also show leak. So we have to address leak by seeing what the cause for this leak. Then if there is thick secretions, we have to apply HME filter or external humidifier. But there's problem of infection with external humidifier. So now HME filter is the choice for humidification. So this is HME filter, which is applied at Y junction between catheter mount and this ventilator circuit. So this will help to humidify secretions. So that's in this module. Thank you. Next module, we will discuss about scalars and loop and dysynchrony. So thank you very much.